Good afternoon, everybody. Thank you so much for joining us today. We are very privileged to have Dr. Bhatt from, is it NUH? I'm so sorry. I've just written, yes, NUH it is. So he is their consultant respiratory paediatrician. He is very kindly going to be looking at paediatric asthma for us today. If you do have any questions during the slideshow, please put them in the chat, and at the end we'll go through them all with Dr. Bhatt. In the meantime, I will pass over to you. Thank you very much.
Thanks, Gemma, for the kind introduction. I've got an hour, but I'm only going to run the slides for about 35 minutes or so, and then we'll have a lot of time for discussion later on. So I'm a respiratory paediatrician, work at the Children's Hospital. I'm also the ICS clinical lead for Nottingham and Nottinghamshire Children's Young People Asthma Network. So what I'm going to talk about today is what's been a paradigm shift in asthma management in children, obviously in adults, but I'm not an adult physician. And the way I'm going to do it is I'll give you a bit of a background about why actually it is important to talk about this, and highlight some of the national reports and initiatives which add weight to the reasons we are all here today and talking about it. And there's one or two areas of focus that I will present evidence about, so that we can try and build up on our expertise as we manage children and young people with asthma. So my first slide, and I'm sure you won't be able to read the small print of which countries it is, but what I want to focus your attention on is that the first panel in the slide, it's looking at comparing asthma mortality in young people from 10 to 24 years of age per 100,000 population in 2016, and that's sort of across Europe. And what you see, the blue bar is UK, and as you can see, we are way at bottom, much higher mortality than many other countries. And if you split them down by age groups, 10 to 14 or 19 to 24 years, you can see that UK does really quite badly as compared to many of the European countries, as much as 10 times greater mortality due to asthma as in 2016. And the emergency admission rate is also one of the highest, as well as the death, which I've shown you. And then when you drill down and look at outcomes for children and young people living in the most deprived areas, then they do even worse as compared to the overall figures. So really, I think we need to change this. And I'm sure some of you or all of you are aware of this report, the NRAD National Review of Asthma Deaths, which was published in 2014. And looked at deaths in children and young people with asthma in the year 2012, and there were sort of more than 165 deaths altogether. But when you focused on children and young people, then there were 28 deaths in 2012. 10 of them were in children less than 10 years, and the rest between 10 to 19 years old. And you would think that this is sort of 10 years old data. Have things changed? Well, the latest data that we have available is from 2018, and the age groups are slightly different, but the numbers are not very dissimilar. You can see that 20 children and young people between 0 to 14 died in 2018 as well. So I think this all clearly needs to change. The NRAD made some recommendations. The report made some recommendations after looking at avoidable factors in both in care that people received for their asthma, and recognition of the risk factors, and by definition also avoidable factors in families, patients, their environments, and also by health professionals. I think really staggeringly, 93% of those people who died in the year before their death had received inadequate routine care. Almost a third of them had inadequate management of their final attack of asthma. And a vast majority, 90%, had poor adherence to treatment or outpatient reviews. And I think really this is something that was scary even for me, which talks about 50% of the deaths being in people whose asthma was considered to be mild to moderate. So it is not that only people with severe, difficult to treat asthma will die from asthma attacks. Even in those who were thought to have mild to moderate asthma actually had fatal or near fatal attacks. And a vast majority of the deaths actually happened outside the medical facilities. Okay, so I think what we need to do, so if they come on intensive care and then they die, then they've had all the treatment they could have had, and it's sad. But these deaths happened outside the medical facility. So I think that tells you that we need to go and look at their overall control on a day-to-day basis and minimize the risk of their exacerbations. So that report made 19 recommendations. Until sort of early 2021, actually, only one of the recommendations had been implemented nationally. And what was that recommendation? That was setting up the National Audit and COPD, National Asthma and COPD Audit Program. Now, the British Thoracic Society had been running an asthma audit for many, many years, but it was sort of a snapshot in the month of November. That then stopped in 2016, and then this National Audit Program, which is a continuous rolling program, that was set up. Okay. So the three key priorities identified by the National Audit Program was that for more than 95% of the children and young people at every contact, but especially in the emergency department when they come in with a exacerbation, you should be recording smoking and second-hand exposure to second-hand smoke exposure. The children should be receiving systemic steroids within 1 hour of arriving to the hospital if they haven't already received this in primary care. And then when they are being discharged, as part of the discharge bundle, you should review or issue a new personalized asthma action plan, and check their inhaler technique, and ensure that there is a follow-up arrangement in place requested within 4 weeks. And as you can see that as of sort of early this year, really we were not doing very well. And these are national figures. These are not just specific to Nottinghamshire, but we were not doing very well. And I think so we need to make sure that we do and ensure that all these things are happening when the children present with asthma exacerbation. So that was sort of the National Audit Program, and only one recommendation had been put in place after the NRAD report. Later on in 2021, the Health Service Investigation Board published a report after a child with asthma died in the north of England, and they came up with certain safety recommendations, observations, and actions. But one of the main things they mentioned was that we should prioritize and ensure that the implementation of all the NRAD recommendations that are outstanding should be put in place. Now, these recommendations were for professionals about being up to date with their practice and all that, but also about organizations and systems. So identifying that there's a need for having a clinical asthma lead, which has now happened across most ICSs. So I think that the theme is that there were many recommendations made, we have not implemented. Start doing that. And it's not just professional bodies and clinicians who were told to do things, and I think the politicians have got on board as well. So the all-party parliamentary group report on asthma was published in February of this year, and then in the background you can see that there are many recommendations from that, and it's very small print. I don't expect you to read that. But the main highlight of that report was that the SABA, short-acting beta-2 agonist, salbutamol, terbutaline inhalers, and oral corticosteroids, when used in excess, are linked with adverse side effects. Okay, and I'll quantify in terms of SABA what we mean by excess. And the all-party parliamentary group report recommended that the NHS should incorporate MART, which is maintenance and rescue therapy approaches where appropriate, and incentivize the reduction of SABA use throughout the NHS. And also that asthma guidelines should include that recognition of SABA overuse, and that there should be suggested alternatives. Now, new BTS guidelines are coming out next year, but international recommendations from GINA, which is an international body that provides professional practice recommendations for asthma, has already done that, and it updates its recommendations twice a year. some of you might have heard of the coroner's report on a child from Birmingham, a child who died with asthma recently. And I think one of the reports, things that the report identified was that the learning point 8 in that report was that the child who was suffering from asthma was prescribed nebulized salbutamol by the GP for use with a nebulizer. And I think then, based on that, I think it was recommended that it should only be done in conjunction with a hospital specialist. And that's what the MHRA alert that came out, which goes to all doctors, all health professionals in August 2022, that the nebulized salbutamol should only be prescribed and initiated and managed by hospital specialists. I have never ever prescribed nebulized salbutamol in my practice. So I think that is something that you don't need to do. I think there are clear safety issues with that. And the theme goes on. I think it's not just the all-party parliamentary group report. There is this NHS program, which is, I'm sorry because you can't see the animation. The slides are now not as they should appear. But anyway, so reducing healthcare inequalities for children and young people in the sort of core plus program. And so there are several conditions, and one of them is asthma. And again, the theme there is that we should reduce over-reliance on reliever medications and try and reduce the number of attacks of asthma. So the overarching theme seems to be coming through that: recognize risk factors, recognize asthma exacerbations, and reduce over-reliance on reliever medications and appropriately prescribe controller medications. So we've been talking about excess SABA use. So how much is too much? Okay, so if you look at the most guidelines, what they'll say is that if people are using more than 3 puffs of the reliever, the blue inhaler, per week, which translates to, say, more than, say about 150 puffs per year. Now, Ventolin has got 200 actuations per canister. So even if you're being too liberal, then you can say at the most 2 canisters per year. Okay, that is what the guidelines recommend. That is what the NICE guidance says. That is what the BTS guidance says. That up to 2 canisters of blue inhaler per year is the guideline recommended use. So anything more than that is excess. So 3 to 6 is definitely quite a lot. 7 to 12 is just too much, and more than 13 is I would say criminal. People should not be having as many inhalers. So this is more than 1 blue inhaler per month. Okay. If you go back and look at the NRAD report, then, so in the year before these people died, they looked at number of SABA inhalers which were prescribed, and in up to 40%, more than 12 blue inhalers. So clearly excess use of blue inhalers. And actually in 4% of them, they were going through 1 blue inhaler a year. So I think if you forget everything else from what I'm talking about today, the message I want to give you is that blue inhaler use is not the primary treatment of asthma, and using it more than the guideline recommended use is positively very dangerous. The flip side of the excess use of SABA is that there is insufficient use of the controller inhalers, either only corticosteroids or corticosteroids with long-acting beta-2 agonists. So this was 2012 NRAD report, but what's the situation in 2022 and in our region? And as you can see that across the different place-based partnerships, more than a quarter of the children are being prescribed more than the guideline recommended use of short-acting beta-2 agonists. So I think this is the awareness that needs to be raised, and we need to look at reducing the use of SABA. This has been known for some time. I think that obviously the attention focus following NRAD and all the other national initiatives has been more. But if you go back and look at papers from more than almost 20 years ago, so this was looking at asthma deaths per 100,000 per year, and this is number of salbutamol doses. So I think more than 200 doses of 100 micrograms, which is sort of 20,000 microgram actuations. Okay, so you can see that once you get to sort of about more than 1.4 canisters per month, then the risk of asthma death escalates quite exponentially. Okay, so that's why we're saying 2 is the guideline recommended use. It should not be more than that. One other way of looking at excess and quantifying the excess SABA use is that look at the ratio of the controller to the total inhalers issued. Okay, so if a child is only having 3 beclomethasone inhalers, but 6 or more SABA inhalers, then clearly the ratio of the controller to the total medication is less than 0.5, and that is a very sensitive marker of increased risk of exacerbations, of having a severe attack. And this was specific to children 5 to 12-year-olds. Okay. There is some more detailed UK data from about 20 years ago, and then this was looking at almost 100,000 people with asthma, and then there were 43 deaths in that study, and across all age groups. For our purpose, they were children as well, 10 to 79-year-old, and then they compared with the controls. There was 20 controls for each case, and the things I've highlighted, even if you can't read it, is that the number of inhalers of SABA, as they increase, the greater is the relative risk. And the flip side of that is the more appropriate use of controllers, less is the risk of asthma deaths. Okay, so that it's a consistent message that's coming through, that excessive use of SABA is associated with a markedly increased risk of asthma death. Okay. And then that's been brought more into focus by this international program called SABINA, short-acting beta-2 agonist in asthma. This is a real world, large population-based study, which has been looking at the use of SABA in inhaled corticosteroids. And actually, the overarching goal has been to capture the burden of current SABA use. So it started off as a sort of SABINA 1, which was a retrospective database study from the UK, and then SABINA 2, which had Canada and then 7 other European countries. SABINA 3, there were 25 countries across the world, and there's a SABINA 4 planned, which is going to include the US as well. The main inclusion criteria for all the 3 pillars was that you should be more than 12 years old and have a current asthma diagnosis. Now, there has been data analysis for the 6 to 12-year age group as well. That is about to be published. But, clearly, all the data so far has been for the 12 years and above. And then what that shows is that when you look at, these are sort of countries in SABINA 2, and, the blue bars are the guideline appropriate use of blue inhalers, so up to 2 per year. And then the other colors are more than 2. So I think 3 to 6, 7 to 12, and then more than 13. And as you can see, in the UK, as compared to other countries, there is, both for mild and moderate to severe asthma, there is more prescription of the blue inhalers and across the range in a mildly excess or significantly excess use of SABA inhalers. Now, this is not to say that there is a direct cause-effect relationship between using SABA and asthma deaths. It might just be a marker of how the asthma control is. But I will show you that actually it's across different levels of asthma severity that this applies. And then secondly, I think it's a signal that if somebody is requiring so much blue inhalers, then you do something about it rather than continuing to prescribe the blue inhalers. So the overall summary from SABINA 2 was, when you look at SABA overuse as compared to appropriate use, which is up to 2 per year, across the steps of BTS asthma treatment, or GINA, step 1, 2, 3, and 4. So step 1 is mild, and 4, by the very nature of the level of treatment they are needing, they've got much more difficult to treat or poorly controlled asthma, and they are on much higher levels of treatment. But across all levels of severity of asthma, there is a dose-dependent relationship between more salbutamol use and asthma exacerbations. So as you can see, across all the 4 steps, and that's sort of overall data. Not just exacerbations, it's also the deaths. So, as there is greater use of blue inhalers, there is greater death in asthma, the greater risk of likelihood of death in asthma. And almost that was replicated in the SABINA 3, which is 25 countries across the world, very different healthcare systems, different health access available to people, different ways of prescribing things, but the consistent message seems to be coming through that as there is more than guideline recommended use of blue inhalers, and there's a dose-dependent escalation of severe exacerbations within the past 12 months when you are using excess SABA use. And that's happening in sort of more than a third of the people with asthma across the world. Not just from the SABINA program, I think there's data from the US as well, which is going to take part in the SABINA program. But when you look at sort of the Medicaid, which is similar to NHS in the US or commercial prescribing, and the blue lines are children. So as there are higher number of canisters being prescribed, there is a greater likelihood of 8 to 14% greater risk of asthma exacerbations. Okay, so dose-dependent relationship between the higher prescription and risk of exacerbations. This was a standalone study from London, and this was published after the NRED report, so in 2016. And you can see that when people were prescribed more than 13 canisters, there was a definite, very statistically significant risk of hospitalization in children when they were being prescribed excess SABA inhalers. So I think it's consistently coming through from SABINA and other studies that high use of SABA, which is more than 3 canisters per year, is common across all severities of asthma, not just severe asthma, all severities. And it's it's more than 1/3 of the people are doing that. And high use is associated with significantly increased risk of death, exacerbations, and also healthcare utilization across all severities, across all sectors. And this has been consistent over 10 years of data. And I showed you that there was a dose-dependent increase in that Swedish data as well. So what is clear is that SABA use alone is unsafe. And therefore, I think treatment and policy approaches are needed for this to change. And I think this has been sort of analogous to what we do for antimicrobial resistance and antimicrobial stewardship. So how we are all careful about when and which antibiotics to prescribe. And I think we should be similarly mindful of doing that with SABA. So I think that's why the ERS has sort of talked about moving away from SABA as a reliever, and this to be replaced by an inhaled corticosteroid containing reliever with a rapid onset reliever as well, as the most significant step towards addressing over-reliance and overuse of SABA in the last 30 years. So do not, excess SABA use alone, it should be discouraged very strongly. So all this is now sort of feeding on nicely into, I think, because of what's happened with the asthma deaths, and I think recognition that things need to change is fed on to the National Bundle of Care for asthma in children and young people. It was published as a draft form last year. I don't think there's going to be many changes when the final report will be published next year. And I think it's sort of looking across the whole spectrum, looking at the environmental impacts of that might be had on the child and young people with asthma, making sure that there is early and accurate diagnosis of asthma, effective controller treatment, and other preventive measures like improving air quality, management of exacerbations. So despite the best controller treatment, some people with asthma can have breakthrough exacerbations, and these should be managed very well. And looking at severe asthma, and this should be happening across the board in sort of educating families, parents, and other authorities, housing authorities, and looking at air pollution, primary care, secondary care, tertiary care, and I think empowering people for self-management and having electronic tools to monitor their symptoms and their lung function and track them over time, and having access to biologicals and other newer treatments. It has been estimated that more than 200,000 people in the country are eligible for treatment with biologicals when we talk about the small group of people with severe asthma, and actually only about 60,000 are on treatment. This is across the board, children and young people and adults. So I think even in that very small number, we need to do better. And the cross-cutting themes across all these domains would be, asthma competencies, and training and education needs for all of us, and having interconnectivity of data and digital components like electronic health records could be accessed by various professionals having asthma apps, or having patient health records like the patient knows best, so that there is sort of seamless communication. And in terms of the education, therefore, what it leads us to is a program which is now live on e-learning for health. This is a framework which provides education and training on 5 tiers, and then the 5 tiers are described based on the level of care a person might be expected to deliver for a child. It's not based on what professional role you have. So it doesn't matter whether you're a doctor or a nurse, but if you have significant involvement in children with asthma, then you might need to do a higher tier of training. So that's basically the fundamental message there. And tier 1, 2, 3, and 4 are live, and tier 5 is more actually about producing a body of a portfolio of evidence of your professional development and evidence that you are looking after children with asthma on a regular basis. So tier 1 is actually for everybody: parents and social workers, nursery nurses, teachers, just raising awareness of asthma. What is the fundamental problem that's happening in asthma, and why treating the basic underlying inflammation and airway hyperresponsiveness with controller treatment is the most important treatment, rather than just using the blue inhaler on its own and other components of care. And so tier 3 and 4. So I recommend that you go to e-learning for health and look for the different tiers and look at which one is most appropriate to you, and undertake the training. So I think, as to distill all this in the very short time that is available to us today, from all the messages that we had from the excess use of SABA and the push that is there in the education in the tiers of training that is available on e-learning for health, the real 4 simple and effective measures that all of us should be doing on a regular basis is to ensure that every child has an asthma action plan in place. Okay, so this is it should be a live, regularly updated document based on the level of control and any breakthrough exacerbations that the child might be having. Making sure that we all understand how to use inhalers correctly, and therefore give appropriate advice to people on how to use the inhalers, parents and children. And doing this regularly and repeatedly, because I think doing it one-off is not sufficient. It doesn't work. I think there is a lot of evidence which has shown that regular reinforcement of how to use the inhalers in a correct manner reinforces the inhaler technique, and then leads to better use of the inhaler. Scheduling an asthma review every year and after every attack as well. So I think if there's a breakthrough exacerbation, the child should be seen, looked at the inhaler technique, look at the asthma action plan, see if their controller treatment needs to go up, see if they need to be referred to a secondary care, tertiary care. And I think be mindful of how much impact air pollution has in anybody with any respiratory conditions, but especially with asthma. And that includes indoor and outdoor air quality. So there might be damp in the house, there might be mold in the house. I'm sure you all have heard and seen pictures of the child who died in Bolton in Manchester area recently, where the house was terrible, atrocious, moldy pictures on the newspapers you would have seen all. So I think indoor air quality, but also outdoor air quality. If they live near a motorway, then air pollution, there's clear link between various air pollutants and airway inflammation, but also parental smoking, parental vaping, all that has an impact. Secondhand smoke and vape exposure, and any allergens, they might be driving the child's asthma. And often it is when things come together. So there might be a pet in the house, but the child might not be sensitized. They may not have a positive allergy test. That might not be too bad, but if there is a pet, they are sensitized, and on top of that, they get a virus. All the 3 things coming together then makes them have a very bad attack of asthma. So I think air quality really is so critical that you need to be sort of asking about every time and signposting the families to the right resource. And I think on the British Lung Foundation website, there are some really good resources that you could direct people towards. in terms of monitoring and trying to improve air quality. So what I will do is I'll now actually switch, and I'll try and show you a couple of slides from my colleague Deborah, who was going to be here and going to be talking about it. But I think what she does is she would have done a practical demonstration of the inhaler technique, but also talk you through some of the changes we have made on our asthma action plans. And clearly on all the asthma action plans from the Children's Hospital, now we mentioned that during an asthma attack, immediate use of the blue inhaler is necessary, but using it frequently means that your child needs urgent help. So it should be a trigger for you to do something different rather than just carrying on doing the same, because over time the effectiveness of this can reduces, and this can be harmful as well. So there is a lot of evidence about this, various biological mechanisms whereby the beta-2 receptor might be downgraded, there might be increased airway hyperresponsiveness, there might be paradoxical bronchoconstriction. There is so much evidence there now, and so that potentially over time it can be harmful. And what is also known, that if somebody is using the blue inhaler more, then they will not use the controller inhaler as much, as we saw from the National Asthma Review Death Report. So, I think there's almost a direct relationship. If you're using the blue that much, you're not using the brown one that much. So what Deborah does is, obviously we go through the asthma action plans, and I'm not going to go into the details of that, but I want you to focus on the inhaler technique, which on the back of the written asthma action plan that we give out to families, we have got this link to the Asthma UK website, where there's a short video on inhaler technique, and I recommend that all of you view that. But the two most important things that you need to bear in mind is that if you're talking about pressurized metered dose inhalers in children, it has always got to be through a spacer. And the important thing to remember is that the inhaler should be shaken before each puff. And the bottom line with the inhalers is it should be slow and gentle inhalation through the spacer. While when we talk about the dry powder inhalers, the difference is that is inhale fast and deep. So a strong, fast, sustained suck will then disaggregate the powder to generate the aerosol, so that it gets deposited in the right areas of the lung to be then able to make the most effective use of the treatment where it needs to be delivered. So I think these are the messages that you need to bear in mind. Aerosol, pre-MDI, always through a spacer, making sure you shake before use, and inhalation slow and gentle. After you have I think made sure that you've exhaled away from the inhaler, taken breath in, breath out, exhale properly, prime the inhaler, put it in the spacer, actualize it, aerosolize it, and then gentle sucks through the spacer. The dry powder, it's a fast, so strong suck that will disaggregate. That will generate the energy to disaggregate the powder for it to be deposited in the right areas of the lung. So I think what I've done is I've sort of run through the issues that we are seeing with excess use of the blue inhaler, and how different national initiatives are telling us that we need to do something about the excess use of salbutamol, the reasons behind that, and also very quickly shown you the importance of making sure that you provide and review the asthma action plan on a regular basis at each contact. Look at and instruct properly on inhaler technique at each contact, because repeated instruction does improve the inhaler delivery and the drug delivery to the lungs. Be mindful of and always signpost families about the air quality, indoor and outdoor. I think across the ICS, we have now started having conversations with the housing authorities and what can we do to help some of these families where the air quality is so poor in the house. And I think there are some ideas floating around, including whether we do a joint visit with a health professional and the housing quality person to be able to help to improve the air quality. So I think it's doing this on a regular basis, and by all of us, we would be able to change the stats from the first ever slide I show you, where UK ranks right at the bottom in terms of asthma exacerbations and deaths. So I've deliberately finished it off in left you 20 minutes time for, I hope, a lot of an interactive discussion now.
Thank you very much, Dr. Bhatt. If anybody wants to unmute and ask any questions, please feel free to do so, or you're welcome to put them in the chat, and I can obviously make Dr. Bhatt aware of any of those.
I suppose the stunned silence means that you're
silence. I'll give it a minute in case anybody's putting in the chat, but that is really, really useful. And I have, because I've been lucky enough to attend a few of your regular asthma meetings that you've been doing, it has made me reflect a lot on my practice, and I always felt that I was quite good with my respiratory practice, but there are certain things that are really basic elements that sometimes we do miss in general practice. Because they seem so basic to us, we assume that they know, and I think sometimes it is getting back to that inhaler technique. So many of my patients can explain their inhaler technique very, very well. If I get them to demonstrate it, how they demonstrate it to how they're saying it are two very, very different things. So I do go through it obviously in person, and I also send the links to the Asthma UK as well via text message, because again, it can leave them very quickly once they do leave practice. So yeah,
I think
that is
isn't it, what you said, because they sort of teach to treat, that I think this is one of the phrases that is being bandied around. So it's not just showing them how to use it, but then asking them to sort of repeat it back to you, so that they can demonstrate that it's been done properly. And I think reinforcement of that every time you do it is so important.
We do have one question come through. So, we've got a couple now coming through. So Bernadette has said there is a limited amount of combined inhalers for under 12-year-olds, especially with fast-acting LABA. Are we supposed to be trying to DPI, which is also difficult?
So I think clearly it would be an off-license use, because MARD therapy is not licensed to use under 12. But I think that's okay, because we are developing the APC guidelines as well, which will help you and empower you to be able to do that. So the PMDIs, you're right, it's only the Symbicort is 100/3 PMDIs. It's very, very, till recently was very hard to get hold of. There are other inhaled corticosteroid and formoterol combinations, and it's only the formoterol that can use it in that way. You cannot use salmeterol, which is part of the serotype. You cannot use that as MARD, but formoterol combination with budesonide, that's the Symbicort, with fluticasone, that's the Flutiform, and with beclomethasone, that's the Foster. Now, Foster is only licensed for use above 18. And all the original data on the MARD recommendations has been for Symbicort. So all the research was done for Symbicort, and those original studies 15, 20 years ago, where across the world, more than 4,000 patients from age 4 to 80. So they were in a wide range groups. And I think some clever 4-year-old Swedish children seem to be able to use the dry powder inhalers, but a lot of our children can't use it below 6. So you are then restricted to a PMDI, which is largely the budesonide and formoterol combination. I'm not going into any trade names. And the GINA guidelines also say that all the evidence and the licensing, even about 12, is for the budesonide and formoterol combination. Fluticasone and formoterol, or beclomethasone and formoterol, are not licensed for use, but if there is no availability of the other inhalers, then can be used. That's what the GINA recommendation is. So Bernadette, does that answer your question?
I think it has. I'll see if she responds. We do have another question. Yeah, Bernadette said, yes, it does. Thank you. Daniela has said that she's working with a young person who has asthma and is actually smoking cannabis quite significantly by what she's put on here. Do we have a link nurse in Nottingham City that she can link in with to discuss any supportive materials?
So I'm a pediatrician. When you say young person, if the person's over 18, then I wouldn't know anything about that. But I think, is the person smoking or vaping cannabis? I think either is equally bad. But I think there's misconception that vaping is safe is total nonsense. I think in children and young people, they should not be taking up smoking and vaping whatsoever. I think there are smoking cessation advisors for adults in City and Queens. But if it's over 18, then I really wouldn't be able to signpost you. You might need to, look up the website. There are people who would be able to advise that young person.
Yes, sorry, just to interject. It is a young person. They are just 14 years old.
Yeah. So I think just being very clear that it's so dangerous. So one thing I was on the national television and press about 4 years ago, and there is even you could look it up still, and there are videos about that. So there was a young person, and this person doesn't mind because he has done a lot of awareness raising. Ewan Fisher, EWAN Fisher, he nearly died after he was vaping. And we published that case, and then it was on national television and everything. And he's put on several things on the, you can find it on YouTube, you can find it on Google. And so you could ask this young person to contact you, and who is easily contactable, to say, look here, how dangerous vaping is. And it was, he was vaping, he denied vaping cannabis, he was vaping nicotine-based liquids, but he might be able to guide that young person. I think it's such a sad story that the official line from Public Health England is that it is illegal to sell these products to children younger than 16, and that's why UK is the only country in the world who is promoting vaping as a safe alternative to quitting smoking. And I have no issues with that being promoted in adults, but I think this gives a wrong message. And you have so many less than 16-year-olds who are vaping. You ask any school, any child, and they will say there are so many people. So I think that's a message that has to come from authorities much higher than. And we as pediatricians have pushed very hard. We published in the newspapers, we published in journals. We've done television programs to say, vaping is not safe. And if it's only when this message is going to go out to everybody that hopefully these young 14-year-olds will not use cannabis, either smoke or vape. So I don't know whether that's been helpful, but I think that's the way it should be.
Thank you, Dr. Bhatt. And there was one more question, or I'm not really sure if it's a question, but Kate, from a practice nurse point of view, I might be able to help as well. So she's put on here about the overuse of SABAs or counting prescriptions of SABAs issued, but actually a lot of the time it's because of the school are requesting they keep one there. Their parents are separated, so they keep one at each house and things like that. So what I found as a practice nurse, Kate, is I have exactly the same issue, but what I do is anybody that has anything over 2 issues per year, it gets flagged up to me. So what I will do is follow on that patient or then that parent if they're obviously too young, and work out whether it is because they are actually using the SABA, whether it's the chemist over requesting, which a lot of the time happens, and they're not even, the patients themselves aren't requesting. And if it's a simple case of they've lost them, because you know what children are like, they put them in their pockets, don't come home with them, and especially teenagers, and whether it's exactly the same thing. So I think so long as we can log in their record that we have followed it up, reviewed them, ensured it isn't because of overuse, but it's for other reasons, then I don't think there's a problem. It's just ensuring that we are actually picking it up, whether it's because of overuse and poorly controlled asthma or not. So, sorry, Dr. Bhatt, but obviously you're welcome to.
You clearly made the point here, isn't it? So the message is that blue inhaler is not the main treatment for asthma. I think that's what you need to be telling the parents, and then try and probe out. So if that child who's got 4 inhalers, one for use at school, one for dad, one for mum, and one for somewhere else, and then that child is being admitted to the hospital every month, then clearly that is wrong. That should not be encouraged. But I think that child's never been admitted to the hospital, and they've genuinely got it at 4 different places, but actually don't use it. But you need to explore that, and I think give the message to the families to say that is not the main treatment. So I think move away from that automatic response that my asthma is playing up, I use the blue inhaler, whether I'm at dad or whether I'm at mum's. No, that's so it should be a flag for you to explore and probe, as Gemma very rightly.
Okay, thank you. There's no more questions in the chat. Anybody is welcome to unmute if you have any questions you've got. If not, then we can leave it there and let Dr. Bhatt get on with the rest of his day.
So if it helps, I'm happy to send the references and slides if it is useful for you guys. I'm happy to send that to you.
Absolutely, if you can, that'd be really helpful, and we can forward that on to everybody that's attended today. Yeah, people are already putting in the chat, yes, please. But thank you very much for your time. It's really, really helpful and useful for us, because I think most of us here are from general practice, so we see it from a slightly different angle, and it's good to have that valuable information coming from you directly and to assist us. So thank you very much.
And I think I'm also extending you all an open invitation. You know, we as what Gemma was alluding to do, we have this network Asthma meetings once a month, and I think it's not a closed group. I think we would very much welcome everybody's ideas. I think the goal is to improve the outlook of children and young people with asthma. So whatever you can do to contribute, even if it's to actively participate in the discussion and learn from it, you're welcome. And I think, you know, any bright ideas, let us know. We want to work together to make a difference to children and young people with asthma.
That's brilliant. And I do get the join-in links for those asthma groups. So if anybody on here would like to join, let me know and I can forward on that invite for you quite easily. Thank you very much, everybody. Thank you very much, Dr. Bhatt. Take care. Bye.